In this pelvic anatomy lecture, what I'd like to do is introduce the concept of arterial supply and the ligaments that support the ovary and the uterus. Now, of course, it's going to be more complicated than this once you get in the belly, or if you look at a netter plate. But what I want to do is talk to you about the gross generalities of ligaments and arteries and use clinical correlates to show you how it can be relevant to you. Let's start off with the ovaries and their vascular supply. This is the uterus, ovaries. Also in the belly is going to be the kidneys with the adrenal glands. The start of the vascular system, the heart, sending off the aorta. The aorta will branch into the common iliac arteries. More on that later. The ovaries are supplied directly by the aorta on both sides. Easy to remember. What changes is the venous drainage. And what you can remember is the ovarian venous drainage mirrors the adrenal veins. The thing that returns blood to the heart is the vena cava. On the right side of the patient, where the structures are close to the vena cava, the veins go directly from the adrenal vein to the vena cava, from the renal vein to the vena cava, and from the ovaries themselves directly into the vena cava. They're each independent and go directly to the vena cava. On the left side of the patient, where the structures are far away, they happen to converge before entering the vena cava. As the adrenal vein, renal vein, and ovarian vein come together before ending up at the vena cava. Now, it's a little hard to say, but it's pretty easy when you put it on the board in color. The last piece of this is going to be the ovarian ligaments. That is the suspensory ligament of the ovary, which contains the vascular supply to the ovary. Much in the same way of when you set up a computer, you want all the power cords from the keyboard and the mouse sticking together and not getting tangled up with everything else, so you put a little thing around them to keep them tied together. Well, that's basically what the suspensory ligament of the ovary does. But the suspensory ligament of the ovary can lead to a problem. This is the suspensory ligament redrawn. And what I'm doing is I'm showing it to you from the outside and then opening it up so you can see what's inside. That is to say, the artery and vein run through the suspensory ligament of the ovary. Now, the suspensory ligament is supposed to keep the ovary in place, but it's essentially a tube with two wires running through it. And these wires are the vascular supply to the ovary. You can see how you could grab this ovary and just spin it. And if you do that, you're going to cross the lines and you're going to squeeze off the vascular supply. Both the artery and vein can be tightened off, and then what you're going to get is poor perfusion to the ovary. That twisting of the ovary is called ovarian torsion. It's exactly what happens in ovarian torsion, especially if this ovary is weighted down by, say, a large cyst. It could twist just a little bit. Just a little bit of twisting twists the wires together, blocks off the vascular supply, and the ovary dies. Surgically, you can get in there, untwist the ovary, and hope that it pinks up. The vascular supply returns and the ovary does well. You simply tack it down so it doesn't do that again. But if you're too late and the ovary has died, you simply remove it. Ovarian torsion is a clinical correlate of both the suspensory ligament of the ovary as well as the ovarian vascular supply. If we talk about the vascular supply of the uterus, zoom in here, what we'll see is that the aorta comes in and branches into the common iliac arteries. The common iliacs are going to become the internal iliacs, formerly known as the hypogastric arteries, and the external iliacs. The external iliacs are going to pass through the inguinal ligament to become the femoral artery as they exit the abdomen. The internal iliac arteries give rise to the uterine arteries. So if the uterus here, fed by the uterine arteries, is bleeding, you may need to stop that bleeding surgically. And the clinical correlate we're going to use here is postpartum hemorrhage. Now, postpartum hemorrhage is unique in the way of hemorrhage. If you take a young, healthy soldier male and have him lose this much blood, he'll be in hemorrhagic shock. Postpartum hemorrhage is defined as 500 cc's after a vaginal birth and 1,000 cc's after a C-section. Because mom has an increased circulating volume secondary to her pregnancy, she can tolerate significant amount of blood loss that someone who is not pregnant cannot tolerate. So 500 cc's and 1,000 cc's is not a big deal for an OB. It's a huge deal for everybody else. But if you cross 500 or 1,000, now you want to do something to prevent mom from dying from exsanguination. The first thing you want to do is non-surgical. And that is going to start with uterine massage. This usually involves putting your fist into her uterus and trying to massage the uterus to stop it from bleeding. If that doesn't work, you may need to step it up to medications. The medications you can use are oxytocin, and oxytocin is the right answer. You also have up here methergin and hemabate. Now I am using methergin and hemabate, the trade names, not the generic, on purpose. Their names are really long and hard to remember and hard to say. They're low yield and they're not the right answer on the test. So you can throw around methergin and hemabate on the wards, but oxytocin, Pitocin, is the right answer for postpartum hemorrhage if you're going to pick it on the test. And if that doesn't work, what you do is a balloon tamponade. I want you to feel that uterine massage as your fist is the same thing as balloon tamponade, which is an inflated Foley catheter. If these things don't work, you're going to have to go to surgery. And in surgery, what you're going to do is try to spare as much as you can. So you're going to start closest to the thing that's bleeding. So you're going to do a uterine artery ligation. If she's still bleeding, you're going to step it up. You're going to go from the uterine arteries up to the internal iliacs. And ligate those. If that doesn't work, you're not able to go one step further, because if you did that and ligated the common iliac arteries, you'd sacrifice the blood supply to the lower half of the body. So you can do uterine arteries, then you can do internal iliacs, but after that, if she's still bleeding, you're just going to have to do hysterectomy. And since you're already in the abdomen, total abdominal hysterectomy is the way to go. Now I'm going to say this and not write it on the board because I don't want you to remember it. But in addition to ligation, you can also do interventional radiology, which will do embolization instead of ligation. And there are some surgeries you can do which kind of compress all the structures to try to do the same thing the balloon tamponade or uterine massage is doing, but surgically from the outside. For this clinical correlate, what I want you to see is, for the uterine supply of the arteries, uterine arteries can be ligated, internal iliacs can be ligated, but then you can't go up any higher in the tree, so you'll just have to remove the uterus. So that's the ovarian ligament and arterial and the uterine arterial. Let's now talk about the uterine ligaments. And this is where you get a lot of clinical correlates and it becomes a little hard to understand because everything's in 3D. So hopefully I'll show you enough that you get a grasp of what's going on. Here's the uterus, ovaries. We already talked about the suspensory ligament of the ovaries that carry the vascular supply and cause ovarian torsion. The uterosacral ligaments, the things that connect the uterus to the sacrum, and this is supposed to imply that it's going backwards to the back, are important clinical structures because they need to be removed when doing hysterectomy. The uterosacral ligaments. They're also the things that look like the ureters. So during a hysterectomy, you must cut the uterosacral ligaments. But if you accidentally cut, as some novice OBs might, the ureters, you cause a urologic emergency, you need to get a urologist in the operating room. So don't cut the ureters, but do cut the uterosacral ligaments. And the last piece of this is going to be the cardinal ligament, the most difficult to understand. This is the pelvic sidewall. The cardinal ligament is going to connect the uterus to the sidewall to keep it in place side to side. But it also forms an anterior and a posterior portion that keeps everything in place front to back. So this is going to require sort of a perpendicular view. The view you already understand, looking head on, it's going to be the uterus. This is going to be a marker of anterior-posterior. You'll see how that becomes prominent in a moment. This is the vagina, pelvic sidewall. The cardinal ligament keeps everything in place side to side. Okay, easy to understand, not a whole lot of clinical correlate there. Anterior-posterior, though, uterus, anterior marker. Anterior to the uterus is the bladder. Posterior to the uterus is the rectum. The cardinal ligament, anterior-posteriorly, is going to keep everything in place. And the correlate here is, if you weaken this ligament, what you get is called pelvic floor relaxation. Pelvic floor relaxation means the things that are kept in line, the bladder, uterus, and rectum, can become out of line and fall down. Pelvic floor relaxation. If the bladder falls down, what you get is a cystocele. If the rectum falls down, you get a rectocele. If the uterus falls down, you get uterine inversion. And all of these are based on pelvic floor relaxation. The pathology of pelvic floor relaxation is large or multiple births. That is, if mom has had a bunch of kids, the uterus has grown and shrunk, she's pushed really hard, she's stretched out these ligaments. And being ligaments, once stretched, they become lax. And the laxity causes the structures to shift. So large multiple births lead to stretched ligaments. The patient is not going to complain of something very specific for all three. What you might see is vaginal fullness, or in a referred sort of way, chronic back pain. But the way you're really going to make this diagnosis is on the speculum exam. And this is entirely a clinical diagnosis. When you do the speculum exam and you put the speculum in, if you see something falling down from the top, that is the anterior, that's the bladder falling into the vagina. That's a cystocele. If you put the speculum in and you see something coming up from the bottom, that's posterior, that's a rectocele. If you put the speculum in and the cervix is right in your face, way closer than it's supposed to be, that's uterine inversion. You're simply going to see it happen. The way you're going to treat this is first with some pelvic floor strengthening techniques. We talk more about this in the incontinence lecture, but really what you're going to need to do is a hysterectomy. And hysterectomy is used for uterine inversion. Or you can use colporphyry for rectocele and cystocele. And colporphyry is actually the term I'm going to use for all of the surgical procedures you could possibly do to put things back in place. There's the MMK, Birch, slings, whatever. There's a whole long list. But all of them do the same thing. You remove the uterus for uterine inversion, and you put the bladder and rectum back in place surgically and hope that they stay there. Now, the thing that's going to be unique to each of these diseases is that you may present with disease-specific. What I mean by that is a cystocele may present with incontinence. We'll talk more about this in the incontinence lecture. The rectocele may present with constipation. constipation that's relieved by inserting 2 fingers into the vagina. And uterine inversion is usually going to present with you seeing it. And so you need to be able to grade how bad the inversion is. This is the normal position of the uterus relative to the vaginal opening. If the uterus is just down into the vagina, but not to the vaginal opening, that's 1. If it is at the vaginal opening, but not outside the vagina, that's 2. If the uterus has progressed outside the vagina, that's 3. And then if there has been full inversion, this is the vagina outside of the body and then an upside down uterus, that's 4. All right, so what we talked about was both the arterial supply and the ligaments of the uterus and the ovaries. For the ovary, they all come together as one ovarian torsion. Spins around, cuts off the vascular supply, unspin it, tack it down. Uterine artery supply has to do with postpartum hemorrhage, and what you want to realize is you can ligate or embolize the uterine arteries first, then the internal iliacs, but after that you simply have to take out the uterus. And the uterine ligament clinical correlate is pelvic floor relaxation, which leads to 3 different diseases: cystocele, rectocele, and uterine inversion, knowing that you need to remove the uterus for inversion and put the bladder and rectum back in place once you find it. The type of person who gets this condition is someone who has large multiple births with stretched ligaments. That is pelvic anatomy.